This next case is a truly not a frequent thing, but a nightmare if you see in the cath lab. It's anomalous circumflex arising from the right coronary cusp, and it has a long and quite difficult looking lesion. So it should be a treat to watch.
Hello, good afternoon.
Mansi, you can go ahead with the history.
Okay, so he's a 72-year-old male patient, known case of hypertension and hyperlipidemia, came with an unstable angina with a normal LV function of EF 60%. His angiogram revealed type C LAD proximal mid-segment lesion and his anomalous LCX arising from right coronary cusp showing proximal insignificant plaque and mid-distal 80% stenosis. RCA show insignificant stenosis and PCI to LAD lesion is already done and his syntax score is 15. So our plan is PCI to anomalous LCX originating from right coronary cusp. His angiogram images are...
Okay, can you hear me?
Yes, we can hear you.
Samir, what do you think should be the strategy? Malcolm, I also want to know from you.
I think we see a wire in the right. That's a great idea to stabilize the guide. And this is an AL1 guide. Is that true? AR1.
AR2.
AR2
Here
guide.
also I am taking AR2.
Okay.
So
And
this is for, I think it would be a good learning even for the new cardiologist, because you feel that how am I going to do this? I simply cannulate the right first, inject.
can we show the live screen, the fluoro screen?
Yeah, are you not able to see?
Now we can, yes.
Scout. Yeah, Scout, inject. Right. Scout. Yes. Let us take one injection here. See now, what I will do is I will deploy one wire in the right. Get me run through extra flow, please. This is the easiest way to do even by the newest operator. That's why I am showing this. Otherwise, I can cannulate, with some difficulty this anomalous circ, but the lesions, regular first primary and secondary curve, Aman. Yes, fine. But this technique will never disappoint even a new cardiologist. That's why, I want to show that.
What about the mid-RCA lesion? Do you think it is not significant?
Pardon, RCA has a lesion.
Wouldn't we fix it first, then go for the anomalous?
I don't know. How many of you think that it is significant? Scout.
I think it's borderline. I would probably leave it
Very
alone.
borderline. If you do, that as you go as per the guideline, the FFR will be 0.9. But let us see. We'll check it in the other views also. This is what it is now. अच्छा सामे father velos ने ले लो तैयार कर दो. Now what I will do is Aman inject.
So you're going to walk the guide back.
Little bit back and clock rotation. Little back and clock rotation. Little back. Still little back. And here scout. Okay.
Tejas, for the learners in the audience, do you want to just remind them which way you were turning that catheter?
Pardon?
Which way were you turning the catheter?
Clockwise.
Clockwise.
Yeah.
Okay.
Inject. I do see there. I will still try to maneuver the catheter a little more. If it doesn't, no worries. Scout. Keep it like this. Get me the wire now. And again, I will heavily depend on the shape of the wire.
So Tejas, this is all about guide catheter choices, and it's,
Yeah.
These are always fun cases to do. This is a really nice technique. I've used this a couple of times, but typically my go-to catheter, and again, this is not to say that this is not going to work. It's a multi-purpose catheter as well. It sits very nicely and points downwards. But this technique of using the wire in the right coronary is very nice.
So if I am doing it myself, I discussed this with even Sanjay. If I am doing it myself, I told Sanjay that I will use hockey stick and finish it. I know that backup support is not there, but here I am going to demonstrate you one stent, which is a Make in India stent, Cruise. It is really cruising very easily, even the long length, so well in this situation. Yes, perfect, perfect.
SIL 0.75 also great option for this kind of. It will sit there directly into the ostium of the anomalous circumflex.
My friend Ajay Mahajan is there, right, on the panel?
Yes, sir.
Ajay,
Yes, he's
why are you so silent?
I am learning. This is a very good technique.
Tejas, your comment there about your plan to use this other stent, that you think this is going to go there very nicely.
Yeah.
It reminds me, the very first GR2 stent that I put in was actually an anomalous circ. And no one thought it was going to be able to be advanced. This is a long time ago, but it just reminded me of that story.
Yeah. You're
And
really dating yourself now.
oh, I know. Actually, I had to do that right in front of Cass Pinkerton,
Oh,
and it was a live case as well. That it may not have been the first one I did, but maybe the third or fourth case. But it was so confident. It was just a revolution in stents at that point, just in terms of where it could be delivered.
Yeah.
But you're absolutely right, Samir. That of course it was a bare metal stent, and then we learned that he had a lot of restenosis with those little gold markers at the end of
Yep.
them.
No, it's coming out. Wait. Today is a difficulty day for me. No problem. Wait. Scout. Inject. 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 If this does not work here, I will need a hockey stick catheter.
The other approach that some people use when they're really having trouble with these, just like any other intervention, is again use of guide extensions if you do not have a stable guide position.
Yes, you are right. Almost there. Yes.
right. You're in.
There we go.
Okay,
You're in.
Okay. Samir, why am I facing so much of problems during these 2 days?
We'll have to check your horoscope.
I'm in so many difficulties for no reason. Of course, for reason, because we have chosen to invite difficulty for ourselves.
These are almost,
by keeping the cases.
yeah, these are almost impossible cases that you're doing.
How many of you think, the lesion is pretty long? Let me simply go in a little more deeper,
Yeah.
and then take a better injection.
So you're still going to do clockwise rotation?
Little bit clock, scout. Yeah.
Can we
No
take
problem.
that RCA wire now?
I will show you in a cranial view. Go to LAO cranial. Show me the distal tip. It is perfectly well placed, I suppose.
Yeah, that looks very good. The wire position is good. I think the flexible stent is the solution.
Okay. So, how many of you are of the opinion that I should pre-dilate, and how many of you feel that I should simply go in and out?
I would pre-dilate because the guide support is tenuous, so better to prepare it.
I have a reason to use the balloon here. Why? I will tell you.
To suck the
Once
guide
I
in.
have-
yeah.
you know it. I know that you know it. But I want to intrigue the young guys what I am doing. Okay, Aman, what are the problems with these anomalous surge? Just discuss with the audience.
So if
Because
shower is
you
concerned,
are inclined towards the structural, so you always think that something happens, wall expands this way, this will happen with anomalous. So just discuss with them.
So if you see anomalous circ originating from the right coronary cusp in a patient who is about to undergo tower, you just don't rely on the
0,
coronary heights. Even if the right and the circ are arising at a height of 16 millimeter, you shouldn't be overconfident that the circ won't be compromised. The problem with this anomaly is that the circ goes behind the aortic valve. Most of these circumflex arteries are retroaortic. They surround the aortic valve in a circle, and when you deploy the tower valve, there is a high chance that you will occlude the mid-circ. So whenever you are encountering such circumflex which are anomalous, you should first analyze it in detail on a CT, because in angio you are not able to realize where it's going from. And then you protect it with a wire before deploying the new valve.
It's a great point. We used to have a sign on the left ventriculogram where you see a dot on the inferior aspect of the aortic root. So just to your point, it's retroaortic and going around. It was a sign described. Malcolm probably remembers.
I don't remember the sign, but you've got someone, I think, on the panel. Is Rajiv on the panel there at the moment?
He's here. He's sitting there. So
He may have a case to share with you with this, which is very contemporary, unless he's going to be showing that this afternoon.
I think Samir, if Rajiv is in the audience, ask him to speak.
He's
something.
going to present that case in the afternoon.
Okay,
Retroaortic circ.
okay, he's going to present that case. Yeah, okay.
Dr. Patel, Girish here. Do you think you still need the RCA wire because it will keep your guide tip away from the circosteum? You might be able to cannulate better.
I agree. I mean, may I know who is speaking?
Girish Godbole.
Yeah, Dinesh.
Girish.
What I feel is I have no issues. But this course we are designing for the new generation of the country to be trained, and that is the reason. I will show them, the safest way, to be successful without any heartburns or apprehension. That is the only reason. Had I been all alone doing the case, I will not even care for that.
What I meant was, now that you already have cannulated, if you no longer need the RCA wire, and with that, the angle of the guiding catheter will be better.
This is what I am trying to show. Now I am going to remove the RCA wire very carefully Karina. And I have a balloon access there. Just remove it. Remove it out. Okay. Now go at 3 atmosphere. Go at 3 atmosphere. 3.
it's a 2 millimeter balloon.
2 millimeter. And deflate it now. Okay. Just pull it back. And now we see it is perfectly well aligned, I suppose. The direction is perfect. Scout. Scout. This is in the other direction. No. Now. Wait. Go in. Inflate. 6.
This is what I thought you were going to do in the first place.
Yep.
Okay, deflate, inject, a little bit
Off center, yeah.
off center.
I think it's a directly down pointing takeoff.
Yeah.
And the amplet's flat
Down.
curve. That is probably closer now.
Scout. This is the closest. No. Scout.
Do you
Okay.
want to try balloon assisted here to see if it goes in?
It can go here at 4. See, up to 4 atmosphere, the balloon, up to 6 atmosphere, 3, 4, the balloon remains very flexible for the guide catheter to move in. Deflate. Inject. Yeah, better. Now we will go in and dilate the lesion.
Samir, your point about it pointing down, that's one of the reasons why I like using a multi-purpose here. It really does direct downwards.
Go to LAO cranial. And I think we have to go further down. This is okay, Sanjay? Small branch. Wire is in the small branch, yeah.
Yeah, and you might want to push it distal too, right? Right there, a little more.
Okay, this is better.
Now we should coaxial, right coaxial.
Shall go up, yeah. Go, 6.
6.
Okay, deflate and see. Where is the... I think this is better. This is the distal part of the lesion. I think so.
Yes.
Then go 6. It's a soft lesion. No problem. Sanjay says that you deploy another wire just to make sure that guide catheter alignment remains perfect.
It's
What
not.
do you think?
It's not a bad idea. I think it'll stabilize your system. That's a good idea.
Same wire go up. Same wire which we have put in RCA, we can 6, 8. Deflate.
Yeah, because the catheter does seem to have a little torque build up on it. Yes, there's some energy in it.
Wait.
Pull the balloon.
Okay, deflate. Just inject and see. Okay, it remains the same. There is a lesion there again. Going further. Okay, go here 8, 10.
Samir, whilst they're doing this, do you want to maybe just ask the panel how they made, what their favorite approach is to dealing with these anomalous circs, particularly in terms of guide catheter choice, wires, 2 wires, guide extensions.
Any comment, guys? If you want to say one by one, what is your choice of guide catheter?
Now let me give me another.
Dr. Lakshman Das, please, if you want to start.
Yeah, as I told before, the short amplitudes 0.75 would be the first choice. It may directly even look into that, and it will give a lot of support sitting in the sinus. And I will go with any overcast wire should have crossed this lesion. The lesion is a very distal, so it may need support. So guide extension, guide plus is a great option to take it further down, because the opacification is not very great here, and most of the dye is going there in the sinus and then right coronary artery. So guide extension will help a lot in at least to reduce the amount of dye being used. And of course, it's not yielding, so I'm not very sure if it is a scoring balloon like Aperta will be very, very helpful here. Distally. There, the guide extension also will be helpful to take that Aperta down.
Now I have done some maneuver to push deploy another wire. Can you show the fluoro save? Yes. I went in with the wire, the same wire which was deployed in RCA. Just show. This is the fluoro save. You will be seeing. Is the same view? Yeah. Now I asked Aman to inflate the balloon at 11-12 in the lesion. Then I asked him to deflate at this point, and then we negotiated in the wire.
That's good. So that would not kick your guide back. Yes.
The most important thing is deep intubation in this particular scenario, because we need some support to push the stent.
Here I agree, Ajay.
So
if I will trust only one guide catheter for my deep intubation purpose, and that is right Judkins. Every single guide catheter which has a different shape can create problem when you want to really go deep.
So I'll prefer 5 French guiding in this type of scenario.
Only issue is the lesion is very long. 5 French, I love it, but only problem with 5 French in this situation is if I am taking a long stand, and if it doesn't it is not being negotiated through the lesion, whatever reason, I am pretty apprehensive. I have heartburns pulling a long stent back inside the 5 French guide because we have seen, five French guide tip damage the stent and sometimes the stent embolization in past. Samir, what do you think?
Yeah, that is a concern. And also air embolization is more common with 5 French
That
PCI.
is all right.
Yep.
5 French means for all the new guys, one must remember if you are using 5 French at every single stage, you allow you open up the cork and allow a generous back bleed to happen every time because it sucks the air. Now let us check it.
That's such an important point, and there was a period where I was doing a lot of 5 French PCI a few years ago.
Okay.
And you just have to do that, otherwise you sooner or later you will run into problems.
Yeah, I think-
Proximal is somewhere around 275-3. Distal is 225. What to do?
I think a 2 to 5 can go up to the proximal size most likely.
So what do you think should be the length of the stent? This balloon is 15 millimeter long balloon.
So that will give you at least 30 some.
LAO caudal. Yeah.
Yeah.
Were you thinking then of not doing intravascular imaging here?
Not before stenting. And then just wait. Remove this. Let us remove the crowding.
So you're confident on the stent size and length here?
Only issue, Malcolm, here is if I am not very good. I know I was interpretation well. I feel that I'm more experienced with the OCT interpretation. So here OCT is a challenge for me because the tip, the lesion is very distal. And the tip of the OCT catheter reaching there, the first tip is a major problem. Inject.
That was partly right. I asked the question what you were going to choose.
Let us inject. Aman has asked for LAO caudal view. He thinks, like a structural guy. So all these views he wants. Yeah.
We can leave the distal diffuse disease.
Distal diffuse disease anyways.
There is some concertina too.
Yeah. So here in that case, I don't need a stent which can be, let me pull this wire back.
You want
Would
to
you agree? I think that your son made a good suggestion there. That becomes looks a bit clearer.
Yeah, inject. This is a 30
30
millimeter
millimeter.
length of the radio opaque area.
I think a 32 or something like that, you think?
No, we have
Or even a 28.
Yeah, he feels that there is a proximal disease, but
Yeah, I
in
would.
that case we have to take a long stent, right?
Yep, I would stop at that branch almost,
Yeah, in that case,
the superior branch.
then there may be, we can take 3 millimeter to start with, deploy at 10, 11, 12, come back and go and get a good pressure there. Is that okay?
The proximal disease has been dilated by a balloon.
Okay, but balloon is 2 millimeter, so no issues.
And there's also some non-obstructive disease, very
Yeah,
proximal.
But 2 millimeter balloon even will not do anything to that area. This area is too big for 2 millimeter balloon. So distal part, how distal we have to go?
I think
It looks like there is ectasia in between,
yeah.
and then there is some segment which few people may interpret as disease, few may interpret as regular one. So what to do?
I think I would stop. There's a tiny branch distally also. I would stop right after that branch. Distally, and there's a vertical branch.
Distally, which branch? Just show me the previous view.
There is a very tiny branch that fills right at the.
Yeah,
Yeah. I would stop right after that and
Come
proximal
back till the
proximal branch.
little proximal to
I
the
think
radio
36
opaque
will
segment, right?
Yes, about 5-6 millimeter, prior to that.
Okay.
Yeah.
So what do you think? 36, 38, what?
I think a 30. If you use Onyx, I would use a 30. A Zion's will be 32 or 28. So we'll have to pick.
I agree.
Curvatures are good for a cruise.
We are going to use
Use a cruise.
in
Oh,
this
okay.
case. And let me use cruise. Only thing is, just like Zion, just like Onyx. I don't know, is this the observation with you guys or not? But like Zion's, I never felt. I mean, 18 is 18, 23 is 23. Onyx and Cruise, when I take a stand, like if I choose 28, 26 Onyx or Cruise maybe 34, it looks like little longer than what it should be. I don't know why. It should not be. They must be keeping proper care, but somehow visually I feel that way. I don't know why. So here I will take 3 by 34. It will look little longer. Cruise
2.75.
275. Agreed. That is a good suggestion because it looks bigger once it
circumference.
inflates, just like Onyx.
Another important thing just I want to share in structural, if there is anomalous circumflex arising from the right coronary and if there is a large ASD without aortic rims, then we have to be very careful because
Yes,
if the chances of
That is what
getting-
we discussed, because if it is the retroaortic course, then the mid circumflex is rotating around the aortic valve. So when you deploy a new valve, it will get compressed in the mid segment. When we think about the
32,
coronary heights,
Sanjay?
and we ignore it that the height is good, but we end up compressing
36?
the mid circumflex. So it
36.
has to be protected.
the same thing happens with the ASD device. So in that case, we must insist for at least 10 millimeter aortic rim to decide regarding
Yes,
the device
yes.
closure. Otherwise, send the patient to surgery.
So we are taking 275 36. Cruise is available in different lengths. So Sanjay says that 36 will be very comfortable. So how many of you feel that I may find some problem, tracking it, or all of you feel that it should be okay?
I think it will go. I just don't know if it'll end up landing in the proximal non-obstructive plaque. That's the only concern of 36. But we'll see. We can always remove it and use something else.
In that case, we can do OCT in that region. That should not be a problem, and we will show. Okay, whether we have landed in. See, OCT imaging. It's very clear. Okay, again, Dr. Akasaka's seminal study. Landing, proximal distal landing. If it happens in normal segment, by and large, the restenosis never develops in that region. Age stenosis. 744 patients study done in Japan, and he has evaluated proximal distal landing with OCT. If it is fat, the restenosis is highest, landing proximal or distal. If it is fibrosis or calcium, the restenosis is absolutely in a modest percentage, not very very high. So if you are not getting a normal segment proximal and distal, then make sure that you don't deploy your proximal and distal landing. You should not be with fat. If the stent is deployed in fat, how good acute result may be, chances of age restenosis will be very high. What is your comment on that?
Absolutely. The lipidic landing is very suboptimal. Yeah.
This stent, when I feel that nothing goes in, I have found that this goes in. This is one product which I love to use. Okay.
I think we have crossed.
I think you're there. I think you're at the distal landing.
Inject.
We are non-selective.
It looks good.
No, we need to go a little bit.
No.
Yes.
No,
That
no.
branch, small branch, is much on.
I think Aman is right. I think you're still proximal.
I'm pushing my guide in.
Yes. Now we can take a
And
selective
then
view.
get me LAO view.
I think that is better
Get
now.
me
It just
LAO
went
view
in a
now.
little bit.
Because we don't now need to see that. And let us check it in this view. Yeah.
Yes, it has
Okay.
progressed.
Inject. Little more.
Just a little.
Little more, yeah. 2 or 3 millimeters more would be adequate.
I think we are there now.
Okay.
Now you definitely are
Let
there.
us check it. Inject.
Now you're there for sure. Maybe,
This
yeah,
This looks good.
Perfect.
Yes.
Go.
yeah,
Can I go up?
looks very good.
Wait. Now, how many of you think that I should remove the other wire, and how many of you feel that it's not needed?
I think
Remove the other wire. I think
I
it should not make any difference.
it would not make a
Only
difference.
if it is a calcified segment and you are using, a very hydrophilic wire like Whisper, there are chances that it can create
This
problem.
is the extra wire.
This is the extra wire, right? So
This,
slowly,
yes.
no, not this.
This one, yes, this is correct.
Okay.
I have a question for Dr. Akasaka if he's able to hear. He's a basic scientist. Is there any difference in the wall histology of these anomalous vessels?
Dr. Akasaka,
This looks perfect.
go.
You can go up to 10.
Huh?
I'll get the answer.
Yeah. Go.
10.
10, 11, 12 here. Reflect. Wait.
Record.
A little bit back. Okay. Go up here.
So I posed the question to Dr. Akasaka, and he has the answer for you.
The question is, there are significant difference between the anomalous SARC and
Reflect.
other coronary artery, right?
Yes, the normal versus anomalous. Is there any histologic difference?
In my knowledge, there are no significant difference, I think.
Okay, that's good to know. Yep. Because I think, from the intramyocardial vessels, the media is a little different, isn't it?
But I don't think so. No.
Okay.
Basically, yes.
Yeah, I never read anything, but I have heard from comments from different people. It's good to know that there is no difference. You treat them like normal
To scout.
coronaries.
Scout.
This is good.
This is the simple original anomalous, right? Therefore, the historical no difference.
I want
But
to select
If there are some anomalous vessel,
then only we can do OCT, not otherwise.
the other
That's
portion,
why-
I would like to say not an origin anomaly, right? That might be
Here, I am
some-
not
some-
able to do OCT. I think I cannot cannulate it selectively. What do you think?
Yeah, I think it's going to be tough without selectively going in to do OCT.
Yeah.
And IVUS might not even go.
Also,
We can try, huh?
Yes.
but I'm afraid the blood flush
What do you
I-
think? No.
not so good,
Yeah,
right?
not so good. Now, how many of you feel that we should check right with OCT or right looks normal? I mean, insignificant. This result is perfectly fine according to me. Any comment on it?
Would you post dilate the mid segment of the stent?
You think so?
Right at the
Because
right
I
at the
am
time.
blinded because I don't have OCT. I don't mind doing it. Get me a non-compliant balloon and that 3 millimeter balloon, NC pipette. NC pipette is again a Indian made. So this time, we have seen good Indian products working so well. I mean, 2 myval cases, this and all these
Wire.
things,
The wire.
which is good. Okay, fine, no problem. સંજય હવે આમે લાઈવ નહીં થઈ શકેલું તો ચાલુ કરજે ત્યાં આગળ ઓર આપણે આઈડિયા વાપરી શકે હા 3 by 12 or 15 get me 3 by 15. I know you guys must be hungry and within 5 minutes, exactly at 1 o'clock lunchtime, we'll make you free. But, it is my humble request to all of you to assemble maybe 245, 145 or so, or 150, or maybe we start with the lecture session and we have some very informative, robust lectures delivered by the authorities in the field. And that is the reason why I am keeping a separate session so that the brain is not clouded between the live cases and the lectures. Okay. Balloon?
It's just at the proximal part of the stent.
Yeah, I would go a little bit, one more balloon length further, right?
Yeah.
At the top of the hill, so to say.
Okay.
Yes.
That looks good.
Injected. You want to? Okay. Go up.
We can see it.
Yeah. Go up. Barabar?
Yep. You can even see the stent diameter is a little bit less there, so it'll look good.
15. Now we are, pushing the struts into the media. Deflate.
Yeah.
Literally. Yeah, you can dilate here also now. And we can dilate 50. Deflate.
And that's the 3O balloon, right?
Stent enhancement, stent boost or something, we will never use it, right?
I was just thinking maybe a poor man's OCT.
Okay.
Just in terms of stent expansion.
Yeah,
So
probably they are not well versed with it, right? We have never used it. It must be there in the system. Deflate. Stent whiz. Yeah, so that is again the same thing. Okay, only during the time of deployment.
No, you can use it even with this.
I think you can use. I'm not familiar with the GE thing, but if that balloon, I think you can still use here for your enhancement.
Deflect. Check it. It looks better now.
It looks better expanded, for sure.
Scout. Inject a little bit.
Yes.
Inject. Yeah, better. Okay.
I think it looks very good. It looks very good.
Wire and see some concertina.
Wire, we are pulling it back and you want to see now, just check it.
Yes, now
It
it's
looks
good.
perfect.
Yeah, I think if you do, it looks
I
good.
think, you guys very well deserve, we are going ahead with the lunch and it is a very well deserved lunch because you have seen us struggling for almost 2 hours for one case to start with me and Sanjay and then with Dr. Saito. But anyways, the end result is good and I am very happy to conclude the live demonstration session of TRICO 2025 and I am indebted to everybody. Dr. Akasaka, thanks. Thank you very much for your very constructive comment and of course Malcolm. All of you are very trustworthy friends who always support us and we look forward to having a great post-lunch session to end the TRICO. Thank you very much.
Thank you. This was awesome. Thank you.